Okay, just letting you know that I'm starting the recording, but as I mentioned, we'll make sure that we've properly edited this before it goes out to broadcast.
So just to remind everyone, this talk will be recorded and it will be available on our website maybe about a week after after today. And there's also recordings of past talks on all kinds of topics if people are interested in checking out any of our past talks. People who are joining us from New South Wales will know that we're all in lockdown at the moment, so it might be a good time to sort of catch up on some past seminars. All right, we've still got people joining us, which is great. How are we going for time? It's just one past. We'll give it one more minute and then we'll get going. It's great to see so many people here with us. How are we going? Look, I think I will start. Just again, welcome everybody to the New South Wales Health Statewide Biobank. And we are very excited to have with us Dr. Craig Willers, who's going to be talking to us about the National A3BC Biobank-Registry model. So I'll just give a brief introduction to Craig and his career to date. So Craig is currently the National Director of the Australian Arthritis and Autoimmune Biobank Collaborative, which is also known as A3BC, which is headquartered at the Colling Institute and the University of Sydney since 2016. So Craig has worked with a number of health and medical research projects across most Australian states, and he's held a number of consultant and staff roles in different settings such as university, state health, hospital, biotech and charity settings. He helped to guide the foundations of New South Wales Biobanking and Bioinformatics Strategy in his previous role as Principal Policy Officer for the New South Wales Office of Health and Medical Research. And he also was involved in the initial development of the 45 and up biobank strategy with the Cancer Council New South Wales. He's also worked with several national biobanking groups on strategic and operational consultancies, and he's chair of the Colling Institute Data and Informatics Research Enabler Committee. And Craig's core interests essentially are developing large-scale, broad capture, integrated biobanking and informatics projects, and his goal is to realise greater collaboration, interoperability and efficiency for more holistic research models and new levels of innovation in evidence-based precision and preventative medicine. And certainly those goals very much align with the goals of the Statewide Biobank. So Craig, we're very, very excited to have you here with us today and we look forward to your seminar. Thanks so much.
Thanks, Jenny. I feel like I should have made that an elevator pitch. It's quite long. Thanks for the opportunity to present today. So I'll be presenting wearing a couple of hats, primarily my role as National Director of the A3BC, but also my, as Jen mentioned, my experience working at biobanks and in state health, etc., on biobanking, bioinformatics. So try to give a broad perspective of what we've done in A3BC and where I think we can achieve more at a national level. So I'll just go through the rationale and vision of the A3B to start with, consent and governance, the scale and scope in sharing of our data, which is quite ambitious, data management and interoperability, cultural and behavioural change, which we all love, and of course funding. So the genesis of the A3BC, why support arthritis and autoimmune research? Well, it's the highest disease group burden globally. 1 in 6 Australians have arthritis, some form of arthritis. It's the most common reason for accessing healthcare services, And there's a chance that if you're over 45 with arthritis, you'll have at least one other chronic condition. So comorbidities are quite high. The costs, so musculoskeletal is the highest health area group health expenditure in the country, which might surprise some people in line with cancer and cardiovascular. The PBS expenditure for rheumatoid arthritis alone last year was over 1.1 billion. And one of the big drivers behind setting up the A3BC is the fact that about 50% of this expenditure on medications is lost due to switching or stopping RA therapy due to poor or ineffective outcomes. But on the flip side, there is very little funding that comes into musculoskeletal research. So last year, the NHMRC gave us 16 million. Cancer received 11 times that, cardiovascular 7 times. The MRFF, we only got 4.2 million. Cancer, 27 times that. Mental health, 26 times that. And the mission funding, there was nothing for arthritis or musculoskeletal, and you can see the figures there for the other main health areas. So it really puts us behind the 8 ball in terms of addressing those health expenditure costs and that disease burden. And this is just a summary of this expenditure in comparison to cancer last year. So you can see MSK, musculoskeletal, was nearly double cancer, yet the research support was about 20 times more with cancer. So a big imbalance there that really makes it difficult for the disease settings. So the core driver was to look at a new approach for musculoskeletal, particularly arthritis research in Australia, and really look at what can enable a new era and efficiency of research. So what we started with was the Australian Rheumatology Association database, which has been operating for around 20 years now. Patient-reported outcome registry. It's been commended by the AAHW, very well published, and has a fantastic group of investigators across the country. The Clinical Quality and Health Commission have also isolated musculoskeletal as one of the leading priorities for registry development. So there's obviously a big driver to support that. And in terms of the information, there's more and more, particularly industry drivers, asking for real-world data to either replace in some instances, not so much with clinical trials, more so to complement the selective clinical trial data that we're seeing. So getting outside of that bias of the clinical trial selection to get more real-world data, and that includes your quality of life measures, environmental exposures, dietary, and we collect quite a lot of those at the moment. Our baseline questionnaire is close to an hour to complete. So the main genesis of the biobank was Professor Lynn March, who's the coordinating principal investigator, was lucky enough to have a patient who benefited from a targeted precision medicine approach a few years ago, and made a rather large philanthropic donation with the core aim of driving innovation and adding value to the ARAD, the current registry. And that was at that point in time seen as a biobank. One of the big things with most complex diseases, particularly with the arthritis, autoimmune diseases, is there's so many known and unknown biological environmental interactions that the level of information, both biological, environmental, clinical, etc., needs to be quite broad to make discoveries that are actually going to translate into health improvements compared to your single gene disorders, which, as we see, get a lot of funding. And as I mentioned before, the main rationale for that is that we have a high rate of ineffectiveness of the medications. So we're the first musculoskeletal/arthritis biobank, national biobank in Australia, and really the first of its kind in the world, given the scale and scope of information that we're collecting and what we're looking to do with it, as I'll go into. At the moment, we've got about 70 investigators on our protocol, about 60 national collection sites that's spread across 6-7 nodes. that are the connection between the collection sites and the processing and storage sites. The vision is really to enable researchers and doctors to better discover preventative measures, diagnosis, precision medicine approaches for arthritis and autoimmune diseases, and hopefully find a cure. The main aims are obviously to develop the biobank. It needs to be longitudinal, open access. Best practices is something that we're quite heavy on, and integrating that biospecimen data with a broad longitudinal array of data sets, which I'll describe in a moment. Then to allow these to be integrated at a patient-centric way to identify associations through data mining, AI, which is obviously taking off a lot in investments and paid publications at the moment. And then to work with clinicians and policymakers to ensure that these discoveries can be effectively translated into prediction tools and policy for precision and preventative medicine. So we're collecting blood, and that's broken down into serum, plasma, DNA, RNA, and peripheral blood mononucleosides, tissues, stool, and saliva. The stool and saliva is collected at a few select sites, whereas the blood and tissues are across the country. As I mentioned before, patient-reported outcomes, there's quite a long list there I won't go into, but that's quite an extensive amount of information and gives us a lot to link to the biological and to the clinical, particularly the dietary, looking at the microbiome for the stool and saliva collections. The electronic medical records, I'll touch on a bit more later on, obviously very important and something that's been highlighted in a number of biobanking strategies, both local, state and national, as a key driver and enabler moving forward. And also looking at their Commonwealth data sets, so Services Australia, formerly known as Department of Human Services, linking in those services and pharmaceuticals claims to get a better idea of what the patient has been through. And these are all taken, all the biospecimens are collected at 0, 6, 12, 24 months. And the data collections are done at the same, and then yearly ongoing after that. So I'll touch on our consent and governance. We're very much trying to lead the space in dynamic e-consent. So we've had a number of people on here talking about dynamic consent, and Nick Zapps, Amanda, I think, mentioned it, Matilda House. What we start with, the first point of contact for the participant is the permission to contact form, which was championed by Peter Watson's group at Canadian Tissue Repository Network, and Candace, who I'm sure is on the line. And that's really the first point of contact to get the information, contact information, and the permission to use that to contact. One thing that we've done recently is looking to partner with a paediatric group whereby we can actually use the permission to contact form to collect some high-level epidemiological information on their disease, which allows us to bring in a partner, but without deviating from our consent model. One of the big functions of the permission to contact form is that within our data system, which I'll describe a little more, that allows us, based on the age and the diagnosis of the form, allows the system to automatically allocate the most appropriate PICF consent form, and that information also goes through to the content of the questionnaires that they're completing. The consents that we have, so we actually have 5 consent forms. We have an adult, a control, children under 14, children 14 to 18, which is completed by the child, and the same one completed by the adult. The reason for that is that we, as I mentioned before, we collect Commonwealth health data, and they won't release that information after 14 without a separate consent from the child. So we've had to develop all those forms. That also, the consent also allows us, given that it's the e-consent and we have everything contained in REDCap, which I'll touch on, that also allows us to link their selection or the authorization of their consent scope through to downstream activity. So whereby if you had a a paper form, obviously there isn't a link between that and what might be permissible to enter data or capture biospecimens. We can use our system to actually link, using branching logic, link the selection of the consent through to the capability of our staff to enter data or perform other tasks. We've gone with an itemized opt-in model, as I'll show you in a second. It's quite extensive, but we really wanted to ensure we don't lose participants because they're a little uncertain about one element, and so we lose the entire participation instead of just giving them the option to opt out of that part of their participation. And our Services Australia have recently approved our consent forms. And I think we're the only ones in Australia that will get that as an in-house form, because they're about to bring out a template which will have to be cut pasted essentially. So it took us a couple of years, but it's quite a good get for us there for our data linkage. So this is just, I hope everyone can see that reasonably. This is a copy of our consent form. So you can see at the beginning on the left there that there's three main options. They can consent to everything, in which case all of the yeses and the ongoing will be auto-populated within the form. They can consent to some, in which case they would then manually go through and select which items they would prefer for each section, or they can say I don't consent to any participation, in which case all of those no's will be selected. So a big part of doing this again was a number of risks. One example would be the negative publicity around My Health Record and breaches around data that they might be uncomfortable with coming into the study because of one item. So we don't want to lose them because of that. They can simply go with option B, some participation, and tick everything except for the My Health Record. You'll also see that they can, if they're worried about their time investment, they can go with a one-off collection of the data and the biospecimen instead of ongoing. So this is the governance model. I might just pull this down. Oops. Okay, so the governance model is broken into our nodes, our states, and national. I think the most important thing to emphasise here is the representation of our consortium committee at the top. I might just see if I can. Okay, can everybody see that? So we really need to be inclusive and bring in our sponsors, the Australian Rheumatology Association, and consumers through Arthritis Australia. Our consumer co-design approach has been quite strong, and something that we're really looking to help with getting through a lot of data concerns and getting that support from the consumer level to drive through to government. And also our international scientific advisory at the moment, we're looking to expand that. The ethical, legal, societal impact is interesting. We actually had a use case come up recently, which is needing to be actioned, whereby there was a question raised about mental health. So we all know about the return of actionable clinical results, but where does that stop? So that's an important question that we'll be taking to ELSI, whereby there's a significant mental health issue identified. Okay, get back into this. So really the core things I think moving forward with any kind of national strategy here would be to make sure that we have critical forward-thinking representation over a lot of resistance to change, which I have noticed, and I'm sure everyone's experienced throughout, particularly the data side of biobanking and the privacy concerns. But we really need to move beyond that and find a balance and focus on doers and disruptors and influencers, not social media influencers, of course. And balance the clinicians and career researchers and decision making. It was interesting listening to Cassandra and the others last week on the VCB organised forum and talking about the unique skill set of biobanking, and in concert with big data moving forward, it really is something that we need to make sure we have in that decision-making pathway. The national HREC management, so that's something that's come up through our discussions, and something that I've had a few discussions with. I think it'd be useful if we could drill the HREC management for biobanking, given the unique skill set, down to 1 or 2 biobanking and big data HRECs per state, and possibly roll the Commonwealth and state health HRECs into these. And that's a discussion I've had briefly with Katie Irvine as part of Cheryl here, and I think there is some interest in that. It just depends how that would look, but that would really help to free up these applications and reduce duplication, people reinventing the wheel, etc. That's also something that has recently gone into a health privacy review through the Australian Office of Health Information, to make sure that the HREC validation of the consent is the most important step there. Okay, so sample scope. So why are we looking at big data? Everyone's heard about the average time to research translation of 17 years. So we really need to be looking at a new scale and scope of data, and that's a big part of the A3BC design. It's a big part of course, everyone's heard of the UK Biobank and other big biobanks across the world. It's really, I think, the only way, the best way to drill down on a lot of that time and those economies of scale. So without the A3BC, researchers would be waiting around 3 years or more, spending $1 million plus a year to get the quality, the scale, scope of data and samples that we're in operation to provide. This has been evidenced by a few people, particularly the Australian Genomics paper by Matilda House, showing about 850,000 over 2 years just for 5 HRECs. So it's quite a time investment, and I think we should be really looking to jump in existing operations and consolidate as much as possible. Also, the output of our biobanks, the funding that is coming through. Everyone loves to talk about funding, but it really is an issue. The UK Biobank have published over 900 papers in 8 years. They've got an imaging bank, and they've just signed 6 months ago, signed on the dotted line with the UK government, Wellcome Trust, and for pharma for about £200 million to do GWAS on their 500 participants. So we're nowhere near that. We're really being left behind, and that kind of scale and complexity of study is something that government's going to have to start backing. Otherwise, we're not going to see the utility and the impact of our biobanking commitments. This is just some basic modelling behind the reasoning for the scale and scope. This was a piece of work done by Rory Collins, the PI for UK Biobank. There's many studies on this, but you can see the sample size here, looking at a cardiovascular cohort, and the standard error moving from 5,000 to 500,000 people, and that's the sort of error that you're going to require to change a model of care or implement a large-scale preventative or precision medicine change. So we really need to be getting that kind of sample size and consolidation of resources. And it really does beg the question, some people might not like to hear it, but is it national, or if not, is it irrational? Particularly when it comes to rare diseases. If we're supporting 10 rare disease biobanks across the country and they're all operating differently, you've got to ask, is that a rational decision, rational investment moving forward? Obviously not. The scope. So there's still, I think, a lot of people, a lot of groups are now moving towards the multiomics or system biology, but there is still quite an imbalance towards genomic focused research. And I think particularly in the chronic disease space, complex disease space, we really need to be considering multi-omics in a more systematic way. One of the main reasons for collecting and storing our biospecimens, our blood, our tissue, etc., in the way we do is that we're really committed to taking a holistic approach to look at rheumatoid arthritis and other inflammatory arthritis diseases, rather than just focusing on the gene. So this is just a figure that I pulled out of a publication showing that of the 3,000 genes in a cell, there's about 1 million proteoforms, so variations of protein coming from those genes. So it really does remind us that what we know, there's far more we don't know. Other benefits, so irreproducibility. We know that if you've read John Ioannidis or others, about 50% of scientific discoveries, some confounding factors there, are irreproducible, and that's a cost of about $28 billion a year on studies that can't be replicated. And sample size, sample and data quality and size are big contributing factors to that. And obviously that's why we've adopted our SOPs and had them certified through the New South Wales Health Biobank, and looking to move forward with ISO 20387 with a bit more funding. As I mentioned before, the developments in systems medicine is really the way forward, and I think the UK Biobank model and the investments that they're getting there is really a testament to that. Another big part of this is that there are a number of biobanks, not so much in Australia, but internationally, that are collecting for specific ethnic minorities, where we're seeing the majority of the biobank collections are Caucasian, yet the underrepresentation of particularly Asian and African is a real issue that we're looking to address as part of projects, collaborative projects and multinational collaborations. But having an ethnic specific biobank, I don't see the wisdom in that. Hopefully biobanks are looking to move away from that ethos. So the comorbidity analysis is a big part of this. I've raised this question before, and variable responses, but if we are looking to really spread the net with our analyses and look at how all of these diseases interact, obviously some a lot more than others, are we really obligated to standardise some of these collections across all of the biobanks in Australia, so that we can actually do that comorbidity analysis across cohorts? Otherwise, we're obviously going to have a lot of difficulty in doing that. And the devil's in the details. The pre-analytical variables, the metadata are really key here. So I have had a number of interesting discussions over the years about sticking to very tight SOP guidelines, but the fact of it is, whilst it might seem pedantic or time consuming, we're really significantly lowering the impact and usability of our resources if we don't stay with that. A PhD pH difference in two large cohorts of blood samples can really rule out your clinical actionability. EMR interoperability is another big one. So using FHIR resources, I'm not sure how many people have heard of that. Fast healthcare interoperability resources. So the new standard for EMR, which is slowly being taken up by the disparate national EMRs. There've been a significant investment in My Health Record to take this on board so that we get greater interoperability. And past that standardization of the data format is the structure. So we're looking at about 70% of EMR data is unstructured, so progress notes, etc. And that costs a lot of money and a lot of time to break down into structured data, usable data that you can do high quality analytics on. There's a couple of projects I'm aware of that $2 million for a couple of years' work for a very small number of specific disease-setting fields. So getting more structured information into EMR will greatly assist biobanking. Safe and accessible high-powered computing obviously going to be required for that, and cardiovascular disease, most common cause of death, so you would want to include them in that conversation. Data management and interoperability. So we started with a full custom build, which was done through Monash University. So this was the foundation of the ARAD, the Australian Rheumatology Association database. Main problem with that, or two main problems, had a security issue with SQL injections, and they also were spending a lot of money on making fairly small updates and improvements to the system, obviously having to go to a developer every time to add in new questions, etc. And so given the functionality increase we're looking at with a biobank LIMS and bringing in more clinical data, we wanted something that could hopefully perform as a unicorn, and provide the functionality for the biobank LIMS and replace all of the registry, and also allow more information to come in at a patient record level. The main criteria for a project was the cost, that it was under 100,000 up front and 10,000 ongoing, fit for purpose for both biobanking and registry requirements, web-based with industry standard protocols, highly configurable to handling longitudinal and multi-site collection. So this was a big one, given our nodal structure, hub and spoke structure across the country. We really needed to have a lot of checks and balances in place there to allow for that cross-pollination of information. Can accommodate automation such as form auto-population. So I mentioned before the pre-analytical variables. We've got a significant amount of those, but obviously we don't want our lab staff to be filling those in for 3 hours. So they're all auto-populated. 98% of them are auto-populated based on a protocol. And if there are any changes to that, then they can simply select from a drop-down list and mark that in a protocol deviation. So captures all that information for us for transparent quality assurance, but doesn't cost us a lot of time. The configuration, so it's based on need-to-know basis. Obviously, the National Data Manager has access to everything. Outside of that, the lab processing staff don't have access to any identifiable information. It's only what you need to know, which is a requirement under a number of regulations. But I think particularly moving forward, we're trying to expand the information coming into A3BC and biobanking in general. Having that data security is really important. And flexible interfacing, import, export. Yeah, I'll leave that there. So what we did, we went out to market to about 10 vendors. This is most of them. The registry, Pulse Info Frame, Ticket Health, you've probably heard of them, Clinica, Invito in South Australia, and RedCap. And the BLIMS was fairly limiting. It was really based on our desire to keep in check with any national developments and keep as collaborative as possible. We wanted something that was being developed at a state or national level or had a high usership. So Open Specimen and LabVantage, which is being developed by the New South Wales State Biobank, were the main obvious choices there. What happened was we initially discounted RedCap as not fit for purpose, and cost was to customize was extremely expensive, and we were about to go with a fully customized solution, but at that time RedCap introduced external modules functionality. So these are plugins and hooks that allow you to customize your RedCap instance without affecting the core code, which most institutions won't let you do anyway. So you can apply those external modules on a project-specific basis or an instance-wide basis. And what we found with exploring those modules was that we could, it was fit for purpose now, and we could achieve nearly all of our functionality. And we also then started looking at, could we make that a LIMS and get the unicorn? And it came out pretty quickly that we could, and we're still developing that, but that's something that's about to be published with biopreservation and biobanking. We had intended to work with Jen and the team at the Biobank with LabVantage, but they've experienced a few challenges there, so just didn't meet our timeline, unfortunately. So this is a system diagram. I'll go out again. So this is, I won't go on about it too long. If anyone wants to have a better look at this, I can provide a link to our pre-publication version on our University of Sydney repository. But essentially what we've done is developed 5 projects within REDCap, and they all communicate. So the main project here is using, brings in through the permissioned contact form, as I mentioned before, that allocates the most appropriate consent form. That also allocates the electronic case report form appropriate for the disease and age, and through to the A3BC questionnaires, which can be which are auto emailed. Also through to the biobank biospecimen appointments, through to the processing, and it links into the sample locator form, which allows you to track the location of your biospecimens on a multi-site basis, both from the level of the rack and the freezer locations, and we've got a mechanism that allows us to track that across all the sites in a fairly autonomous way. And then the other main projects that tie into this is the self-referral. So the PTC form and the consent form can either be completed in clinic with one of our staff, or they can self-refer. So if they go to our website, they can complete the permission to contact form by themselves there. The only difference there is that we need to verify their diagnosis, so we will check that before we activate it, and they are sent the consent form by their email. The other the end point of this is, once we have all of the specimens accrued, or enough specimens and data accrued, obviously we'll start taking access applications, and that's completely managed within REDCap as well. And this model follows the UK Biobank, where we approve the researchers. That's a once-off preliminary application, full application using their HREC form, material transfer, and we track the any outputs, any publications through an access ID that's unique to the project. There's just a couple of visuals of some of the forms. So this is the blood processing form. You can see here the different types of bloods coming in from collection sites with their volumes and their transport temperatures auto-populated. And just a guide on the blood, the vacutainers. This is a really nice diagram that my 2IC Tom Lynch made up for our electronic case report form, and allows us to put in joints, swelling and tenderness. One of the things we're looking at doing at the moment is working with starting with Royal North Shore, but hopefully going to most national EMR vendors to create electronic case report forms that are agnostic to those. So what you would see is an electronic case report form that has heavily structured information at the top, Once you get near the bottom of the form, we have a progress form, progress notes section that is predominantly free text, but does auto-populate some of the structured elements from the top of the form, and that can then be cut pasted into any EMR system. So it allows us to standardize and improve the progress notes going into those EMRs, whilst also capturing high quality structured information for our system. And this is just a quick visual of how we represent our scanned tubes within the racks, and below this is the freezer location. This is a recent development with REDCap, their dashboards. It's quite nice. So you can see here what we developed this is an internal dashboard. There'd be another dashboard that we'll be making up for external, so for prospective researchers. But you can see here you've got a breakdown of the scope of informed consent given, the participants per state, time points reached within a longitudinal design, diagnosis, etc. So quite a nice little summary. I think that the beauty of REDCap is really the potential of it to provide solutions to particularly EMR interaction integration. So these are a few slides that I've taken from Paul Harris, who's the founder of REDCap at Vanderbilt, who I talk with somewhat regularly. And they designed, had this structure of pulling clinical information into a de-identified and identified research data warehouse and through into their REDCap. But the main problem with this was, and with data warehouses in general, is a time for transforming. So it's not a real-time turnaround with the usability of the data. So they quickly moved to this model, which leverages the FHIR resources I mentioned before. So having that standard data format and bringing all that information straight into REDCap. This is just a visual of one of the REDCap forms within the Epic EMR. And I'll just quickly go through a few use cases. So this is where they've actually embedded the REDCap clinical dynamic data pool tool into Epic. So that's why there's all the information blacked out. And you can actually add, so what's happened here is you've got your patient record, REDCap tab, which is embedded into the EMR, and they can simply click on that to bring up this form, add patient into that project or into another project, and that will transfer all that information into a ECRF or other form. They can also do this for multiple patients to make data marts. So similar to the single patient scenario, I'll go back to similar to the single patient scenario, putting in the time frames, the MRI, MRNs, and other criteria. You can identify a cohort of participants and bring those through into a new project. And then the last one, which is really taking off and really exciting, is using this for clinical trial management. So where we've got multi-site clinical trials, you can use specific, so separate Epic and REDCap interactions. So here we've got one site, two site integrating between the REDCap instance and Epic. Obviously, between hospitals, they're not going to have the trust, not yet anyway, to share their Epic information. So this is why they use a segregated model whereby the clinical data coordinating center, which is a central REDCap, brings all this information from the various sites in a de-identified way into that clinical data coordinating center, and then that can be used for clinical trial management. This is the basic process that they go by. So we have a similar process for whereby we identify some participants through pathology markers that are identified. So the candidate MRN, so this might be a blood marker or something else, will be identified. That MRN will be pulled into a screening database. You'll have a coordinator go through this information and confirm the eligibility of the participants randomised into the clinical trial. It's taken over into a data mart, which is all of your eligible participants, and that will stay there and is continuously updated through, again, the FHIR resources that any new information coming into that patient's record is pulled into the database there as well. And then, as I showed you on the previous slide, so this is one instance I'm talking about, they all then go up into the data coordinating center, generally as de-identified information, but I think they're doing it as identified as well, and into a data lake or data warehouse, hopefully organized and doesn't become a data swamp. And that can be used for research or for clinical reporting. And so this isn't something that's experimental. This is across EPIC and Cerner. They've got about 50 instances across America and a couple of big studies that are doing this. And it's now not just pulling data. There's now at least one publication that is pushing data into the EMR. So this is really, I think, groundbreaking in terms of the way that we can interact with the research data in a fairly seamless way to pull in information for the EMR and interact with the clinical trials. So just conscious of time. So REDCap, I think, is a fantastic tool for small biobanks up to national strategy. It's low cost, easy to manage. I mean, we've built that. I shouldn't say we. I've done a little bit. Tom and Vibhasha have done a lot, and they're not coders, they're not developers. It's something that people with some IT skill can do. Highly flexible, always growing. So the external modules I mentioned have a community repository that people can make up their own external modules. They can develop one that's already available, and the more they become popular, the REDCap central office will just integrate that into an update. So you won't have to worry about integrating an external module. It'll be automatically part of your next update. One of the big things, as I mentioned, with the 50 sites, is that health and EMR vendors now trust REDCap. It's being used quite a lot. There's a lot of security testing that's been done locally, I'm aware of, and no dramas. And you can also, one of the big advantages is that the REDCap uses the Australian Access Federation. So your institutional credentials are used to log into the system, and that adds a great deal of security for the institutions. And from a clinical, particularly a clinical perspective, the instant data flow from this model is quite a big advantage. When we look at other, particularly with unstructured data, but anything that you need to transform, you're looking at weeks to months, even a year, to get that information back to a state that's clinically actionable and in a time frame that's actually usable. Whereas with this REDCap model, it's instantaneous. So add some powerful analytics to that, and you could have, within minutes, a clinical decision event that you could use. So I guess cultural and behavioural change, I think, is the biggest challenge with biobanking space. I still get calls probably once a month from someone saying, can I get some advice on setting up a biobank? And 9 times out of 10, I say, don't do it. Look what's already there and jump on board and improve based on what's already existing, and leverage the infrastructure that's already there, because I think we all know there's a lot of that going on. Focus on custodianship, not ownership. There isn't really any IP in biobanking until it's used. So those that are concerned about IPR pre-analysis, it's a waste of time. Discuss the precision medicine and preventative medicine dependently. So we seem to have a dichotomy of that conversation, but there is quite a large degree of crossover, and that's something that we try and integrate into our funding applications, whereby we have clinical trials we factor in a longitudinal use of the data and the specimens so that we get the most out of that investment, and so does the funder. And combining this power is, really critical for driving more complex discovery, assisting transparency, and tackling the irreproducibility. Jen's done some fantastic work with this paper, and her work over the years looking at errors in gene sequencing. And as mentioned before, John Ine's papers on irreproducibility. So I think a core to this is balancing the risks and the benefits, particularly in discussions I've had with the Australian Information Commissioner. They're very interested in this as well. Consumer co-design is critical here. I think particularly riding the social media wave and generating that nation scale voice, as we've seen with a number of other things, is now changing things. So it's a bit of a paradigm shift in the way that we can change behaviour. And I guess one example of that is the ethics. Patients don't want massive consent forms, whereas HREX like to impose that on us. So I think that's something that needs to be addressed. And we need to put a bit of investment into phishing. We know very, very little and a lot of information invested in these biospecimens that I think we, with big data and artificial intelligence moving forward, we need to realise that the Socratic methods change. It's no longer ask a question and get the data. We've got the data and you ask the question. And Pornhub. So this is just an illustration of how the use of data has changed. 5 to 10 years ago, my wife is in digital marketing. She told me about this. I'm blaming her. The use of user data, the porn industry was completely streets ahead of everyone else. Fast forward 5 to 10 years, Facebook and Google completely dominating, but now it's the data brokers. So these groups that are selling off our information, and it's not really filtering through to the health industry and to research. One thing that has happened recently, which is fantastic, is that the UK government have thrown a lot of money at the UK supercomputer in Cambridge, which is linked to the UK Biobank, and that's going to really start drilling down on all of that information in the UK Biobank. So you see a lot more papers coming out of that. And an interesting thing recently, the federal court has recognised artificial intelligence as an inventor. So that has a number of implications for how we'll manage IP moving forward. But if you think that big data and artificial intelligence is a flavour of the month, then guess again, we're not quite at the Terminator stage, but we're getting there. So I'm just conscious of time. I'll wind up. So I think we really need to, and I've had this discussion with Dan Catchpool and others, that is a bit of chicken and egg here, that funders are asking for rationale for their investments, and we need to build the resources to show that and get some use. So we need to develop a living business case. Part of the funding, I think, will come through from the data side, from the Commonwealth's digital roadmap. Government have been fantastic. We were lucky enough to get 2 of the New South Wales biospecimen collection grants, but I think there needs to also be a mechanism to promote use. And a big part of that, I think, will be generating funding programs that partner researchers with industry and are mandated or centered around big data and biobank use. Insurers, they're outside of patients and the health system. Health insurers are paying a lot out to claims that they may not need to with more precise medical approaches. So I think that's something we need to think outside of the square a little more and look at that option. And as Cassandra and others mentioned on the webinar last week, I think specialist training, PhDs, and education are a big part of that. And then the last thing I'll just say is, I think a number of discussions have been had recently through ISBA and other forums about the name Biobank. Is it too static? Is Biobank a project? I mean, it's an evidence generator. It's something to improve health and improve a resource to improve health and healthcare. And I think we need to communicate that a bit better. There's a lot of ideas how, but time will tell. Biospecimens are essentially unharvested data sets, and I think we need to kind of focus on that a bit more and focus on the data. So the low-hanging fruit that I mentioned at the beginning, I think we can do a lot better. I think we have some fantastic groups across the country, a lot of really skillful people, really passionate people. I think we just need to look a bit more collaboratively at a national level to see what we could achieve and how that may influence funding and investment into the future, and stop trying to look at the low-hanging fruit. I'm sure we hear this expression all the time. And from an agricultural perspective, if you're growing a plant, the first thing you do is cut the low-hanging branches, and it helps the tree grow. So I'm not sure that's a great analogy. I'd just like to thank Professor Lynn March, who's a coordinating principal investigator and founder of A3BC, Tom Lynch, Basha Chan's a national data manager, our sponsors, University of Sydney, all our PIs, and our main funder, the Clearbridge Foundation. Thank you.
Thank you, Craig. That was fantastic. So I'm getting a bit of echo. I might, yeah, if anybody's not on mute, Craig, I might ask you to jump on mute just for a sec. Yeah, look, that was great. I took a lot of notes. We don't have a lot of time for questions. I can see that Dan asked a question about the definition of biobanks, and I think that you've kind of answered that towards the end of your talk, which was very well judged. I don't know whether you're reading the chat as well as talking, but so look, I might just jump to a question from Toby Baldwin from the Biobank, which I think I was thinking about as well. Yeah, just about, increasing dependence on big data. Do you risk sort of finding stuff that kind of is in the data as an artifact, or, due to the data just not being accurate? Is there a risk that you can just shoot down a path that isn't really real because the data have got some sorts of issues? Now you're on mute. I asked you to mute yourself, John. Sorry about that.
Sorry, it's a great question, and something that I've really been trying to push as my role as chair of the Data Informatics Committee at the Colling Institute. There's a lot of buzz around big data and AI, but as I mentioned, maybe not clearly enough in the discussion, is that we need to look at the front door a bit more before we look at the back door. And that's mainly in respect to the quality and cleanliness of that data and the structure of that data, because one of the big problems with big data and AI, as Toby's alluding to, is that a lot of it's using unstructured data, and so you're having to clean all of the crap, and there's a lot of classification differences, coding variations, ICD-10, etc. You've all heard that before. So we need to firstly standardize, and the FHIR protocols are a big part of that, and that's being propagated quite extensively nationally and more so internationally. And then look at how it's structured. So look at the information that we're pulling in, and either change the way that we're entering it, which I think is the best way, the most cost-effective way, or you're going to have to throw a bunch of cash at transforming it into usable data.
Thanks, Craig. I think we've got, anyone's got a really quick question? I think we've got time for maybe one more. Just watch to see if anyone puts up their hand. I think I was actually looking for a link, but in terms of, discussions around biobanking and what biobanking needs to achieve at a national level, I'm sure many of you are aware of the National Research Infrastructure Planning process that's on at the moment. So if you haven't already, registered to be part of those discussions, there is an ideas jam at the moment in terms of promoting interactions between infrastructure and industry that's actually running until early September. So if you just type in National Research Infrastructure into Google, you'll probably find the link. We've got a question from Sarah saying, very interesting talk, especially interested in how you created custom REDCap modules to manage your workflow. Are you planning on releasing that? Is that part of the paper that you talked about for biobanking?
Yeah, so it's discussed in there to some degree. There's a bit more detail in the supplementary tables in regard to those external modules. We didn't create them ourselves, so that's been a number of discussions that I've had with the University of Sydney in regards to their current capacity for development or desire to. At the moment, it's just not resourced. So we went to a group at Monash University who did that at quite low cost. So we used external modules that were already available on the public repository site, and we just changed the code a bit to suit us.
Fantastic. That's really good to know.
So we made an estimate of the costs in the paper. It's about $40,000 of everyone's time, including that coding, about 250 hours. So, you know, if you compare that to some of the commercial providers, it's a significant difference.
Thanks, Craig. Look, I think in the interest of time, we will wind up, but that was a really great talk. And I think you've raised a lot of, you know, a lot of challenges for the biobanking community. I think the need to focus upon use as opposed to samples in, and that need for data integration, the national vision, and the fact that we're probably collecting a lot of things that aren't used, and that's not a good use of resources. So I think you've provided a really inspiring example of a national resource. Congratulations on building that with many people. I think it's a great example for the biobanking and biomedical research community, and just thanks so much for joining us today.
Pleasure.
Thanks to everyone who was here.
If anyone wants to follow up on REDCap or other queries, just drop me an email.
Thanks very much. Thanks, Craig. Thanks, everybody. The talk is recorded, so if you missed the beginning, you'll be able to catch that in a week or so. Thanks, everyone.
Thanks, everyone.